If you're in medical school or taking a fellowship exam or a board certification exam or any exam for that matter, in which management of status epilepticus forms a part of your syllabus, this is the video for you. And this will allow you to recall this in less than 10 seconds. It's an absolutely fantastic tool for any exam going candidate. There's bonus content at the end.
Learn a GAMT, feel the beat. In every learning zone, you'll reach the feed. From cliffs to riches, you ditch the glitches.
Welcome to GAMTPEDIA. This is Dr. Karthik. For people who are new to this channel, I am an assistant professor in anesthesiology working in Dublin, Ireland. This channel is all about the transformative power of cliff-assisted memory technique, or GAMT. Learning is not just about memorization, it's a multifaceted journey. And in this channel, we explore all the aspects of learning, starting from creating a GAMT to applying the GAMT framework, all the way to creating effective recall strategies. Let's jump in. The status epilepticus is defined as 5 minutes of continuous seizure activity or 2 or more seizures without full recovery of consciousness between them. This is the core definition of status epilepticus given by the Neurocritical Society in 2012. And then there's an operational definition as well, which is provided by the International League Against Epilepsy, ILA, in 2015, where there's T1 and T2 times. The T1 is the initial threshold, which is 5 minutes, which is used for initiating treatment. And then the T2 is neural injury threshold, which is 30 minutes, after which permanent neurological damage starts to occur. Okay, so that's kind of the overall definition of status epilepticus that we need to know about. Okay. This is the GAMT for the management of status epilepticus. So we have a boat. There's a small hole in the boat here, and water splashing inside the boat like a jet. You have a lot of air bubbles forming on the side. You have a sea water here, and I think this sea water is frozen. I think that's probably why you have this straight lines, the wavy lines. It's like a Titanic. It's a mini Titanic. Okay, and then you have 2 paddles for paddling the boat, and you have a small flag on the boat. Can't remember, castaway, kind of sounds something like that, similar to this. Then you have the sail with a kind of started in the bottom and then the top. Okay, and then this boat is called ABC just because it's ABC. Okay, so ABC is kind of 2 underlines here, and it's actually sorted by this design. Okay, so that's the boat. There's holes, there's bubbles, frozen ocean, and 2 paddles, and the name of the boat is ABC. Okay, if you just close your eyes and try to recall all the components of this GAMT, I'm sure you can do it in less than 10 seconds. Okay, so that's all you have to remember. So once you finish watching this video, you can map all the management strategies onto this GAMT. Okay, so let's go in. So I'm going to talk you through the GAMT first, and then we'll look at the individual aspects of this GAMT. The first component here is this zone, the name, the ABC, with the underline and the design around. Okay, and the 2 paddles, which is all in red. That's the first component. That's the first phase, if you may call it, in the management of status epilepticus. So the ABC stands for airway, breathing, circulation management. The first line on the underline stands for IV axis, resembles the letter I, stands for IV axis. The second underline, resembles the letter I again, is for investigations. Okay, and the design around this has 2 letters embedded in it. The one on top is letter U, a lot of U's combined together, which stands for underlying cause, and the bottom side of that resembles the letter M, stands for monitoring. And then this paddle resembles the letter P, which stands for Pabernex, and this resembles the letter D, which stands for dextrose. Okay, and then we go to the next phase, the outline of the board itself. This resembles the letter D, stands for diazepam, and then you have the water jetting out. This part of the jet of the water coming into the boat resembles the letter L, it stands for lorazepam, and this, so there are 4 jets. Okay, so one jet is L, the other 3 jets together form M, letter M, which is for midazolam. The benzodiazepines that are more commonly used are diazepam, midazolam, and lorazepam. Okay, so we'll go into the detail in a minute. And then we go to the bubble in the sea. So the number of bubbles on the base of the ship, which resembles the letter F, which stands for phosphenetoin, and the C, the top layer of the C, resembles the letter S, which stands for sodium valproate, and then the lines in the sea, as I told you, is the frozen ocean. That's what's caused the hole in the ship in the first place. This resembles the letter L, which stands for levetiracetam. Okay, so these are the anti-seizure medications, that is the next phase of the treatment for status epilepticus. Okay, and then we move on to the next phase, where the flag here has 3 sides, which stands for 30 minutes. So when the seizure lasting for more than 30 minutes, you getting into the territory of permanent neurological damage, and you have one eye here, which stands for intubation. The other eye stands for infusion. So this is the phase where you start thinking about starting infusions, which is midazolam, propofol, and phenobarbital infusions, and you probably might end up intubating the patient at this stage if the seizure hasn't stopped. Okay, so 30 minutes infusions and intubation is the next stage of treatment, and then you have this stands for letter E, stands for EEG monitoring. This stands for letter C, stands for continuous. So continuous EEG monitoring is another mainstay in the management of status epilepticus, which is prolonging. That summarizes the GAMT for the management of status epilepticus. We'll just go into detail of each element and dissect them out, okay? When you approach a patient with status epilepticus, the first things to do are obviously A, B, and C: IV access, investigations, monitoring, and trying to identify the underlying cause. ABC stands for airway breathing circulation, as you know. Make sure the airway is patent, put the patient in the recovery position if feasible. Make sure you have IV access to, if possible. You need to also get bloods and urine samples for investigations, which is very important to establish the etiology of status epilepticus. You need to make sure you attach the monitors, the pulse oximeter, non-invasive blood pressure, and EEG monitoring. You need to think about the underlying causes of why this happened. Okay, things that you always keep in your mind in approaching anybody with a seizure are these two paddles: D and P. D for dextrose, P for Papernex. Dextrose stands for hypoglycemia, which can cause seizures. Papernex is for patients with chronic alcohol intake or chronic alcoholism who has severe thiamine deficiency. It can cause Wernicke's encephalopathy. So it's important that if you're suspecting Wernicke's encephalopathy or alcohol withdrawal seizures in somebody, you give the Papernex before you give the glucose. The patient may also have hypoglycemia at the same time. This is because Papernex has thiamine, which is also a cofactor for the enzyme pyruvate dehydrogenase, which is important enzyme in the aerobic pathway. So if you give the glucose without giving the Papernex, if somebody is deficient in thiamine, it can actually cause severe lactic acidosis. Okay. Anytime we talk about etiology of a neurological disorder, it falls under 5 categories. Now, so this is taught to me by my neurology professor back in the day when I was in medical school, and it's still in my memory. So first, thumb stands for letter T. This stands for trauma, tumor, toxin. This stands for I. So the index finger stands for infection. This is middle finger, stands for metabolic or electrolyte imbalance, endocrine imbalance. This is ring finger, where anyone would like to have diamond ring in the ring finger. So that stands for D. It stands for degenerative and demyelinating disorders. This little finger stands for little blood supply, or anything to do with reduction of blood supply. This can be ischemia, or it can be hemorrhage, etc. Okay, so these are the 5 major categories for any neurological diseases or issues or events for that matter, right? The same applies for seizure as well. The most common cause for status epilepticus is non-adherence to anti-epileptic medication, which is the number 1 cause. The second most common cause is any acute vascular event like stroke or an infarct or hemorrhage, and then you have the infections afterwards. One of the investigations that you're going to do in this patient, the bedside investigations, blood glucose, vitals, and EEG, immune infection of treatable causes. Then you do the blood test, complete blood count, electrolytes, renal, liver profile, and toxicology, obviously, and infections, metabolic issues, stroke toxicity. Imaging will be the next thing. MRI won't be apparent, but CT brain probably, to rule out any tumors or trauma, identify any structural anomalies. CSF analysis, lumbar puncture, root sinus infections, EEG conditions, EEG monitoring to confirm moment seizure activity. So these are possible investigations you can potentially do in a patient with status epilepticus. Okay, so that covers the initial part of the management of status epilepticus. We're going to go to the next phase where you give medications to control the seizures. So the initial line of treatment is always benzodiazepines. Always benzodiazepines, just because the onset of action is very quick. So these 3 benzodiazepines that have been extensively studied for the treatment of status epilepticus: diazepam, midazolam, and lorazepam. The drug of choice here is lorazepam. It's 0.1 milligram per kg. IV lorazepam is the drug of choice for status epilepticus, then followed by midazolam. If you don't have an IV access, you can give IM midazolam, the dose of 10 milligrams or 0.2 milligrams per kg. If you don't have an IM or IV access, rectal diazepam is also a very useful drug in the management of status epilepticus. Okay, so in whatever way you look at it, the benzodiazepines forms the first line of treatment in patients with status epilepticus. The reason is because of the quick onset and quick control of the seizures straight away. Okay, of these 3 benzodiazepines, lorazepam is the most commonly used and it's most effective. So this comes out of this trial, which is published in New York Journal of Medicine in 1998, I think, yeah, where they looked at patients with status epilepticus or generalized tonic-clonic seizures, and they used 4 different combinations of anti-epileptic medications, including lorazepam, phenobarbital, diazepam, phenytoin alone. And what they found, they have like around 518 patients in the group, around 113 in each of the category. What they found is the lorazepam has the highest instance of seizure control. statistically significant than phenytoin, which only 50%. There was not much difference between the three groups, but lorazepam seems to be very well tolerated, minimal side effects, and also has the highest ability to control the seizures. So lorazepam is the drug of choice for status epilepticus at the start. Okay, when you look at these benzodiazepines, look at the lorazepam, the onset of action is 2 to 3 minutes. The duration is 12 to 24 minutes. It actually has 6 to 12 hours of anticonvulsant effects, kind of much long lasting. Diazepam can be IV rectal, 10 to 30 seconds, kind of super fast onset. It's even quicker than lorazepam, but the duration is only 15 to 20 minutes. So if you don't give any other medications or any anti-seizure medications, the seizure is going to recur in more than 50% of the patient after 30 minutes. So it's very important that if you give any of these benzodiazepines, that you actually follow it up with anti-seizure medications. The midazolam is another drug, which again has a very quick onset and again very short duration as well. Now, it left me wondering, because diazepam has a really long half-life, same as lorazepam, but why does diazepam's seizure control last much shorter than lorazepam? Lorazepam is lower lipid solubility. Diazepam is very highly lipid soluble. So this high lipid solubility enables it to enter the brain very rapidly, and that's why you get a very rapid onset of effect of diazepam. It's actually within seconds. In 10 to 30 seconds, you get a seizure stoppage in diazepam, whereas lorazepam takes 2 to 3 minutes. Okay, so the onset is slightly slower in lorazepam. So why does it actually have a very short duration of action? Because of the redistribution. Obviously, because of the high lipid solubility, it's rapid onset. But because of the high lipid solubility, it gets redistributed rapidly into other tissues, which means that the concentration of the brain goes down rapidly. So hence, the duration of anti-seizure activity is very small. So it's very short, but seizure control is longer in lorazepam, but actually the redistribution is less in lorazepam compared to diazepam. The other important difference between the two is for the affinity for GABA A receptor. So lorazepam has a very high affinity for GABA A receptor compared to diazepam, which actually has lower affinity. So this allows it to exert the anti-epileptic action a lot longer than diazepam. Okay, and the doses here are lorazepam 0.1 milligram per kg, max is 4 milligrams. Midazolam is 0.15, 0.3, max is 10 milligrams. Diazepam 0.15 to 0.2, max is 10 milligrams. Okay, so very similar doses. 0.1 milligram per kg of lorazepam seems to be the magic number. 4 milligrams the maximum dose. Okay, that covers the two phases. Phase one is the initial resuscitation phase, followed by the second phase, which is where you treat the patient with benzodiazepines. Two phases completed. Next, we move into the next phase. As we saw already, the benzodiazepines have a very short duration of action. If you don't give anything in the next 20 to 30 minutes, you're going to have recurrence of seizures. So you always have to follow benzodiazepines with anti-seizure medications. Okay, so what are the anti-seizure medications? Three medications that are most widely studied are fosphenytoin, which is the bubble in the water here stands for the letter F, stands for fosphenytoin. The surface of the water, which resembles the letter S, stands for sodium valproate. And then the frozen C lines here stands for letter L, stands for levetiracetam. Okay, the doses are 60 milligrams per kg for levetiracetam, 40 milligrams per kg for sodium valproate, 20 milligrams per kg for fosphenytoin. Okay, very important that you give the anti-seizure medication, any one of these anti-seizure medications, after the patient had the benzodiazepines. Okay, of the three, levetiracetam is the most commonly used, most tolerated for management of status epilepticus. Okay, now where does this come from? So you have another big study which is going to publish in New England Journal of Medicine 2019, where they looked at the three medications and patients who had status epilepticus. So trial of three anticonvulsant medication with status epilepticus. So they had 384 patients, children and adults, with benzodiazepines refractory status epilepticus, and they divided them in three groups. One group received levetiracetam, the second group received fosphenytoin, third group received valproate, and they actually found no difference. So you can actually use any of them. But levetiracetam is easy to administer, and it is more tolerable side effect profile compared to fosphenytoin and sodium valproate. Instead of sodium valproate, you have to be careful in pregnant patients and patients with liver disease. In terms of fosphenytoin, there is a chance of you having hypertension or cardiac arrhythmias, including bradycardias, in fosphenytoin. So the fosphenytoin is a prodrug of phenytoin. It has to be converted to phenytoin before it starts to work. The reason why fosphenytoin is preferred to phenytoin, the IV formulation is much more stable. It doesn't precipitate with other antiepileptics. The complications to watch out for when you're giving infusions of anti-seizure medications include hypertension, cardiac arrhythmias. Patient might need endocrine intubation. There might be seizure recurrence, acute respiratory depression, death, etc. So finally, coming to the next phase, done the initial resuscitation, you're given the benzodiazepines, you're given the anti-seizure medications. Now, the seizure doesn't stop. What do you do? So 30 minutes is kind of the cutoff time. So beyond 30 minutes, if the seizure persists, there's going to be significant neurological injury. So at that point, you have to escalate it to the next level, which includes, so this stands for 3, so 30 minutes. And this stands for I, stands for infusion, this stands for intubation. The 2 I's. One is infusion, one is intubation. At this stage, when the seizure is persisting more than 30 minutes, you should consider infusion, conditioned infusions of midazolam, or propofol, or phenobarbital, one of these agents. When you start them on infusions, you probably need to support their airway. The patient won't be able to breathe on their own, won't be able to maintain the airway. You probably need to intubate these patients. That's when you call the anesthetist. That's when we come in. Okay, so more than 30 minutes is the time where you start thinking about infusions, either midazolam, propofol infusions, or phenobarbital infusions, and the patient might need intubation for airway protection and ventilation. Also, we also need to have continuous EEG monitoring. So this stands for C, this stands for E. So continuous EEG monitoring is to make sure that there is no non-convulsive epilepsy still going on. The patient might be visibly not seizing, but there might be underlying seizure activity which can be only picked up by EEG. So it's very important to monitor that as well, because that can still cause neurological damage. That's the management of status epilepticus. Initial phase, ABC, IV laxus, investigations, monitoring, underlying cause, diazepam, lorazepam, midazolam, phosphonatoin, levetiracetam, or sodium valproate. After 30 minutes, infusions, intubations, continuous EEG monitoring. When you're in an exam in a viva setting, all you have to remember is this ship with the hole in the bottom. This is the GAMT you need to remember. You get all the facts, okay? So coming on to the bonus content I was telling you about. So I don't know if you guys use Notion. Notion is a fantastic database management tool. But what I've done is created a Notion book or Notion page for this management of status epilepticus. So if you watch my previous videos, I've talked a lot about the GAMT learning frameworks. What I've done is applied that GAMT learning framework or deep learning framework onto this topic. So you have zone 1, which gives the overview, and then you have figures, control the figures of corporate issues. And then if you go to the topic content, it kind of gives you the sources of the information. And then I have the GAMT for the topic in the zone 2. Zone 3 is elaborative interrogation. So all these questions: when was seizure status epilepticus first described? Who discovered epilepsy? What is status epilepticus? And why does status epilepticus happen? All these sort of questions is why questions, right? What is the pathophysiology? How does SE cause brain damage? What is ESET, ETD study? What is the mortality rate? So all these things, all these questions that pop up your mind, the answers for all of them are here. Then you go to zone 4, which is analogical reasoning, and compare and contrast lorazepam, diazepam, compare and contrast the 3 drugs. What is the relationship between the 3 drugs? Compare different GABA inhibitors, receptors, so compare different status epilepticus guidelines. Okay, so loads of stuff here. And then you go to associations in between topics. There's a link to GAMT for epilepsy that I've used for studying when I was in doing anesthesia exams. Again, GAMT for benzodiazepines. So the links for those are there as well. So you can actually view them as well, I think. So and then I have links, and parents are a bit older, so look at the elderly population status epilepticus. So those associations are here. You can build up on these on top, obviously. Then you have short answer questions from asked in the anesthesia exams in the past. Then you have multiple choice questions, again asked in the exams in the past, and specific multiple choice questions on this particular topic. You can look at the answers as well. And then you have zone 7, where applying knowledge. You have problem-based learning questions, and you have I generated some 5 questions from ChatGPT, and then the answers for those questions are here as well. And then you have the research and innovation. You look at research ideas, potential innovations, business areas, recent updates, recent developments, all this sort of stuff, right? So so you don't have to remember all these things, but this will give you a nice context around this topic, so that you have a much more stronger foundation to remember this topic. Okay, so GAMT is like a small sprout. When you apply the GAMT deep learning framework, it's like applying a soil, a nice manure around the sprout, which makes it stronger. And then you obviously need to recall this. That's recalling is like watering the plant, so it allows it to grow and flourish, and your roots are going to be much more stronger. The synaptic connections are going to be much more stronger if you constantly revise and recall this GAMT. So the link to this Notion document is provided in the description below. Please have a look. All the best to your exams, and I'll see you in the next one.